Okay, good morning, everyone. Today we're going to do truncus arteriosus. This is again going to be in quiz format, so please keep your answers ready. So we'll start with, can you have a pulmonary artery that arises from the aorta and yet have a pulmonary valve? And yes or no answer. So can you have a situation where pulmonary arteries both come from the aorta, yet there is a pulmonary valve present? As you know, in truncus, pulmonary arteries come from the aorta, but there's no pulmonary valve. Anyone? Yes, no answer. Everybody needs their coffee. And just click in your answer to everybody. So the answer is yes, you can have a situation, it's very rare, but you can have a situation where both the pulmonary arteries arise from the aorta, the right ventricle gives rise to the pulmonary valve and the main pulmonary artery, and that's usually supplied through a duct, but the PAs are coming from the aorta. That's a rare situation. So if there's no pulmonary valve, we call it truncus. So if you've got both the PAs from the aorta, there's no pulmonary valve at all, no MPA from the RV, then that is your truncus arteriosus. Now, what can you define truncus? What is the definition of truncus? When you're asked, how do you define truncus arteriosus? Anyone want to take a shot at that? Define truncus arteriosus. Anyone? Looks like am I not seeing the chat? Definition of truncus arteriosus? So basically, it would be a single arterial vessel with a single semilunar valve, yes, which supports, arises from the base of the heart, gives origin to coronary, pulmonary, and systemic arteries. So a single arterial vessel with a single semilunar valve, that's part of the definition, because as I showed you, you could have a single artery and have both semilunar valves. A single arterial vessel with a single semilunar valve that arises from the base of the heart, gives origin to coronary, pulmonary, and systemic arteries. Okay. Now, the single semilunar valve is not in the definition, but it's important for you to understand that you've got that single vessel giving rise to pulmonary, systemic, as well as coronary arteries. Now, next question, what is the embryology of truncus? What is considered, why does truncus arteriosus happen? What is the embryology? Because of what part of what happens in fetal life? And is there any genetic association that you know with truncus arteriosus? 2 questions for you. So yes. So it is considered an incomplete or failed separation of the embryonic truncus. So it's a conal abnormality can be there, but truncus arteriosus itself is where that trunk does not septate the way it is supposed to. So it's a failed septation of the embryonic truncus arteriosus. So that is the Latin term truncus. The truncus arteriosus basically is persistence of that truncus. And yes, it's associated with DiGeorge, but more than DiGeorge, really with the 22q11, because sometimes you can have the deletion and not have DiGeorge. So 30 to 40% of them will have micro deletions within that chromosome 22q11, and faulty migration of the neural crest cells is considered to contribute to the pathogenesis of truncus. That's right. So it does have genetic association. Need to send fish for 22q11 deletion when you have a diagnosis of truncus arteriosus. Okay, what are the clinical manifestations? What are the features of truncus arteriosus? You can put them in a line. How do you diagnose clinically truncus? What are the symptoms and what is on exam that you see in truncus arteriosus? So what are the typical symptoms in truncus arteriosus? So we know it presents in the neonatal period. What are the typical symptoms? Anyone? Symptoms of truncus and then clinical exam in truncus. So heart failure. Yes, so the baby, because the pulmonary artery is connected to the aorta, and when the pulmonary resistance is low initially, you get overflow into the lungs, so you present with all the features of heart failure. But because there's mixing of the blood into that single trunk and then to the pulmonary arteries, you will have cyanosis. Initially, cyanosis is there, then it disappears because they're in heart failure, so they have increased pulmonary blood flow. So you have mild cyanosis typically initially, and then over time, the cyanosis get better or worse. Over the, say you untreated truncus, what happens to cyanosis over months and years? Cyanosis increases or cyanosis decreases? So typically the cyanosis increases as they get pulmonary vascular damage. So in truncus, even though it comes under cyanotic heart disease, in the neonate, early infancy, because you have so much pulmonary blood flow, you don't really have visible cyanosis. So your stats will never be 100%. It'll always be 92, 94%. Over time, as you get vascular damage, you get more and more cyanosis. Okay, so heart failure and some cyanosis. And then what on examination? Tell me a few key features. You said click. Okay, click of that abnormal truncal valve opening. Any other key feature of clinical exam of truncus? So diastolic murmur and truncal regurg, wide pulse pressure. So before you guys get to murmurs or auscultation, wide pulse pressure. Now, can you get a wide pulse pressure or a bounding pulse without truncal regurgitation in truncus? So can you get a wide pulse pressure or a bounding pulse? Yes. So you remember that a bounding pulse or a wide pulse pressure is a feature of truncus, even if there is no truncal regurgitation. Why? Because the pulmonary arteries are coming from the aorta. In early infancy, the pulmonary resistance is lower than systemic resistance. So blood preferentially goes from aorta into pulmonary arteries. So there is a runoff from the aorta into the pulmonary arteries. And so it acts like a duct. So you'll have a wide pulse pressure. Now, obviously, if you have truncal regurgitation, it's even wider. It's like, but even without truncal regurgitation, you can get a wide pulse pressure or a bounding pulse. And that should be one of your clues. If you have a kid who is desaturated, has a wide pulse pressure, even before you put your you may not diagnose this on by your stethoscope, or even before you do your echo, you should be thinking, this is not a duct because he's got a little bit of desaturation. This is likely a truncus arteriosus. So slight cyanosis along with wide pulse, you think of truncus arteriosus. So this we discussed. And then on examination, he has an active precordium, he has bounding pulses, he has a wide pulse pressure, he has an ejection click. If you can hear it, listen carefully for the single second heart sound because he doesn't have a pulmonary valve. So there's only a single S2. And then you get your systolic ejection murmur from all that flow. Why is there an SCM? All the pulmonary venous flow, systemic venous flow, everything is going out through that single semilunar valve. You can get an SCM. You can get an MDM because why do you get an MDM? Why do you get an MDM in truncus? And that MDM, if you know, it is described as absence of silence. It's not very classically heard like in MS. It's an absence of silence. You just kind of hear anything. So why are you getting flow across the mitral valve? Because the blood is going out to the trunk, going to pulmonary arteries, coming back through pulmonary veins, and increased flow across the mitral valve. And then, yes, you can get your diastolic, high-pitched murmur with truncal regurgitation. Why is it high-pitched? Why do you get a high-pitched murmur with truncal regurg? No, not high PA pressure. Anything else? What where is what is the truncal valve is leading to what? Let us say it's a newborn, right? And let's say the let's say the pulmonary arteries are stenotic and PA pressure is low. Will you still have and you have truncal regurg? Will you get a high pitched murmur? So what is true is that the high pressure is causing the high pitch, right? But where is that high pressure from? From the anyone? Here? From the aorta, that's right. So if you see here, I'm trying to annotate. Okay, never mind. That annotation is not working. Okay, forget that. So if you see, yes. So if you, well, systemic vascular resistance. Well, it's from the aorta. Basically, the truncus is leading to your aorta, right, and then to the pulmonary arteries. So even if your pulmonary vascular disease and all that hasn't happened, your aortic pressure is high. So your truncal pressure will always be high. From the get-go, your truncal pressure is what your normal aortic pressure is. Now, the thing is that the diastolic, because your truncal regurg happens in diastole, if your pulse pressure is very wide, you may not have such a high-pitched murmur, but generally still your diastolic pressure will be in that 30-40 range. So you get a diastolic high-pitched murmur because it's a high-pressure system. Now, the reason I'm specifying this is there are other situations where you may have a little cyanosis and have a systolic ejection murmur and a diastolic murmur. Any other situation you can think of? Cyanotic heart with systolic diastolic murmurs. What's your other differential diagnosis? A child in distress, yes. So TET absent valve, right? So when you think of TET absent valve, what is the pitch of the diastolic murmur? There it is a low pitched murmur because it's from the pulmonary artery and it's a low pressure system, right? So that is how clinically you will be able to differentiate TET absent valve from truncus. One, by the pitch of the diastolic murmur, if there's a diastolic murmur in truncus, and two, how do you differentiate these two? Before putting your stethoscope, how will you differentiate TET absent valve from truncus without your stethoscope and without X-ray echo? So TET absent valve can also have a little cyanosis because it's mixed, right? And truncus can also have a little bit of cyanosis when there's a high pulmonary blood flow. But the pulse pressure, your pulse, just put a finger on the pulse. If it's bounding, it will go with truncus. If it's a normal pulse pressure, it will go with TET absent valve. So when you, of course, TET absent valve, you have respiratory distress, respiratory symptoms. But many times when a kid comes in, he's just in distress. You heart failure, you're confused. He's breathing fast, he has active precordium. You put your saturation at 93%. Put a finger on the pulse. Bounding, think truncus. Normal pulse, think TET absent valve. Stethoscope, if you have systolic ejection murmur, you will have low pressure diastolic murmur in TET absent valve, high pressure diastolic murmur in truncus. Yes, so Sneha's question is high PA pressure can also cause a high pitched diastolic murmur, and that is true. So, for instance, in situations when you have a VSD with pulmonary hypertension, right, and you have pulmonary regurgitation, that PR murmur will be high pitched because absolutely that pitch has nothing to do with lesion. Pitch has everything to do with pressure. My point to you is that in TET absent valve, PA pressure is low, so it will be a low pitched. In truncus arteriosus, it will always be high pressure because the trunk is leading to the aorta. So the cause of the high pitch is not because of the high PA pressures. Even if you have, a pulmonary artery stenosis in truncus, you will still have a high pitched diastolic murmur because the cause of the diastolic murmur is the fact that the truncal valve is leading into the aortic pressure. Is that clear, Sneha? Okay, so now can you get a continuous murmur in a truncus? I told you all said you can get Bounding pulse, you can get ejection click, single S2, systolic ejection murmur, little MDM, diastolic murmurs in truncal regurg. And yes, if you have branch pulmonary artery stenosis, which is rare but can happen. So why do you get a continuous murmur when you have truncus with branch PA stenosis? Why do you get a continuous murmur? Because, yes, there is a systolic as well as a diastolic gradient through the PA. If you think about it, your aortic pressure or your truncal pressure is going to be, let's say, 100 by 30. If you have a gradient of, say, 40 millimeters, so now what happens? Your PA pressure is 60, diastolic will be, say, 10. So you have in systole as well as diastole a gradient from truncus to the pulmonary arteries, and that's when you get a continuous murmur. So differential diagnosis of continuous murmur with cyanosis is what? Give a few lesions that give you continuous murmur with little cyanosis, with some cyanosis. Apart from truncus with branch PA stenosis, anything else? Continuous murmur with cyanosis. Yes, so pulmonary atresia with collaterals, right? Yes, TOF or pulmonary atresia with collaterals. You'll have desaturation and you'll have the continuous murmur. So again, things to keep in mind. And pulmonary atresia with collaterals, will they have bounding pulse or normal pulse? Well, it depends. If they have a lot of pulmonary blood flow through their collaterals, they can also have a bounding pulse. So that's where it becomes tricky. Now, if you have a high-pitched diastolic murmur, it will go in favor of truncal regurgitation. Yes, if they've got very tight collaterals, not much blood going through them, they can have a normal pulse. But if they're a situation of pulmonary atresia, high flow with, which present in heart failure, that is one variant of pulmonary atresia, there you'll again have continuous murmur and wide pulse pressure. So again, that differential diagnosis can be a little difficult clinically. So chest X-ray findings. What is a chest X-ray finding in a truncus arteriosus? When you see this combination, you should think of truncus arteriosus. Plethora, cardiomegaly, high uptake of LPA, okay, coma sign, right arch. Yes. So in general, if you see plethora with a right arch, it is suggestive of truncus arteriosus. So plethora, right arch, think of truncus. Of course, you can have other lesions as well, but it's suggestive of truncus. So coming to that question, when you've got that diastolic murmur and you have truncal regurgitation, right? Do these kids present earlier than regular truncus or later? Any earlier or later presentation? Earlier. What is the incidence of truncus with truncal regurgitation? How many percentage? How many percentage have? How many percentage of truncus have truncal regurgitation? Come on, you all didn't read and come. I gave you truncal quiz as the topic. So percentage of truncal regurgitation in truncus? Yes, so greater than 20, about 20%. So that truncal regurgitation is, as you know, is because of an abnormal truncal valve. Can be dysplastic, it can be prolapsing, it can have annular dilation, it can have, the cusp can be all odd. So it's about 20-25%. They have earlier presentation with more severe heart failure, and they actually have earlier vascular damage as well. And why do they have early pulmonary vascular damage compared to other kids? Why does truncal regurgitation have a worse prognosis? Any idea? Why would you, truncus, okay, untreated, they'll get pulmonary vascular disease. Why with truncal regurg will they get even more pulmonary vascular disease earlier? So yes, both systolic and diastolic pressure in the PA applies to truncus, yes, and that will damage the vasculature. Why does truncal regurgitation have a higher incidence of or earlier pulmonary vascular disease? So where does the truncal regurg go? It goes into LV, right? That increases which pressure? LA pressure. What does LA pressure increase? Pulmonary venous pressure. So when you have truncus, you have both systolic hypertension in the pulmonary artery as well as diastolic hypertension in the pulmonary artery. So that leads to early vascular damage. In addition, you have pulmonary venous hypertension if you have truncal regurgitation. So it's a double whammy situation for the lungs in that situation. Now, with this on the topic of truncal regurg, in truncus arteriosus, how many cusps are there commonly? You know, you can be uni, bi, tri, quadri, penta. Which is most common? So tricuspid. I know you want to say quadri, but tricuspid is most common, 69%. Next is quadricuspid, 4 cusps, 22%. And then is bicuspid, 9%. And then the rest of your stuff, smaller incidence. So tricuspid truncal valves are still most common. That's the number of cusps in truncus arteriosus. Now, once you've diagnosed, so you've thought that this is truncus, you think you've diagnosed it, what blood work should you send in a patient with truncus? Okay, so fish for 22q11 deletion. Anything else? Calcium. So please remember calcium. Measurement of serum electrolytes, because commonly it's associated with DiGeorge. You can have hypoparathyroidism, hypocalcemia. So you need to measure total and ionized calcium and treat it if it's low. You don't want to be like so focused on the truncus that now this kid is having a seizure because we haven't checked his calcium. And send off fish for 22q11 deletion. Now, let's get to the types of truncuses. So what is type 4 truncus? What is type 4 truncus? Okay, so that is type A4 truncus. So type 4 is no longer, if you read your books, type 4 truncus is what they used to call pulmonary, they used to call it the truncus which had collaterals. So now it is not actually a truncus, it's really pulmonary atresia VSD with collaterals. So type 4 truncus is not a truncus. Type 4 truncus is actually pulmonary atresia VSD. So really there's only type 1, 2 and 3 or type A1, A2, A3, A4. So in your two classifications of truncus, the 1, 2 and 3 is whose classification? 1, 2 and 3. Well, so 1, 2 and 3 is Collett and Edwards. I know it's a little confusing when you read the book, and that's why I'm spending a little time on the classification. So 1, 2, 3 is Collett Edwards. A1, A2, A3, A4 is Van Praagh. That's right. Right. So A1, A2, A3 is Van Praagh. Okay. So let's get to the types. Now, type 1, A1 of Van Praagh is type 1 of Collett and Edwards, right? So A1 and type 1 are the same, which is you've got your main pulmonary artery, kind of a MPA from aorta and branching into right and left. A2 is your type 2 and 3. So what is type 2? The pulmonary arteries come off the truncus, but they have a little separation between them. They are still coming off posteriorly. In type 3, they're coming off laterally. So there's quite a bit of separation between the PAs. You can see here in your Collett and Edwards. In the Van Praagh classification, A2 is the same. A2 means pulmonary arteries are coming off the truncus, either close or far, but they don't have an MPA. They have separate origins from the aorta. Now, what is A3? A3 is the pulmonary artery is absent on one of the sides, and you've got collaterals going to that lung. So if you see in the Collett and Edwards, you just really need to remember 1, 2, and 3, right? Now, if you go to Van Praagh, it's a little more complicated. So if you would like, you can just try and remember one, but most people will want you to know both and at least know what is Colette Edwards is easy, 1, 2, 3. But one prog gets a little more complicated. So you need to remember A1 is where there's an NPA coming out. A2 and A2 is where the PAs are coming out with separate origins. And A3 is an absent pulmonary artery. All clear on that? Now, when you have an absent pulmonary artery, right? Few questions on that. Is the pulmonary artery in a truncus absent on the side of the arch or opposite to the arch? Okay. And in tetralogy of Fellow, what is it? So yes, so in truncus, it is typically the pulmonary artery is absent on the side of the arch. So if it's a right arch, the RPA will be absent. If it's a left arch, the LPA will be absent. Whereas in tetralogy of Fellow, pulmonary artery is more frequently absent on the side opposite of the arch. Okay, good. So what is one prog type A4? So one prog type A4 has really nothing to do with the truncus, but it is really related to the coexistence of an aortic arch issue. Now, it's not just interrupted arch. It could be interrupted arch. It could be coarctation. It could be tubular hypoplasia. It could be any of those. So one prog type A4 doesn't really tell you about the origin of the branch PAs. They could be coming as main. They could be coming right, separate, very separate. But it tells you that the truncus is associated with an arch abnormality. So that is your type A4. Now, let me take one step onto this right aortic arch. And can you tell me which cardiac lesion, overall, not just truncus, but which cardiac lesion is most commonly associated with the right aortic arch? TOF, you mean tetralogy, regular tetralogy? So TOF, absent valve, truncus, pulmonary atresia. So pulmonary atresia. So most common is pulmonary atresia VSD. And remember, that is different from TET absent valve and that is different from TOF. It's your subgroup of pulmonary atresia, long segment pulmonary atresia, VSD, multiple collaterals. So they have an incidence of a right aortic arch, which is over 40%. What is the next most common lesion that has the right aortic arch? Second most common. Second most common is truncus, which is in the 30% range. So, you know, when we talk about that X-ray, right? So the X-ray, if it shows a right aortic arch with plethora, it's most likely going to be truncus. If it shows a right aortic arch with oligemia, it's most likely going to be right aortic arch, oligemia, oligemic lung fields. It's most likely going to be pulmonary atresia VSD, yes. Now, you have rarely the pulmonary atresia VSD with a lot of collaterals that may present with plethora and a right arch, but those are unusual. The vast majority of pulmonary atresia VSD have reduced pulmonary blood flow and pulmonary oligemia. So when you see a chest X-ray and it has a right aortic arch with oligemia, it's pulmonary atresia VSD. A right aortic arch with plethora, you think of truncus. Okay, all clear on this point? So I'll move on to the next, which is what are the associations with truncus arteriosus? What are the, when you see truncus, and these are cardiac associations, what are the other things you should look for? One we said interrupted aortic arch, right? Coarctation. What else? What are we said right aortic arch? Those we've covered. Any other associations? So coronary abnormalities, they can have high takeoffs, left SVCs. PDA can be absent, PDA can be present. Right? 50% is absent, 50% is present. Yes, so absence of PDA is one and presence of PDA. Yes, absence of PA. So if you have absence of pulmonary artery, which type? One prog, which type is it? Absence of pulmonary artery. One prog, which type? A3. Yes. So no, not A4. A4 is arch issues. A3 is absence of a pulmonary artery. All clear on that? So associations with truncus: right aortic arch, interrupted aortic arch, around 15% average, frequently associated with DiGeorge when you see interruption, absent PDA or present PDA, unilateral absence of a pulmonary artery, which falls into your type A3 of one Prag, interrupted aortic arch falls into type A4 of one Prag. Coronary ostial anomalies, truncal regurgitation or stenosis, ASTs, left SVCs, and rarely even PAPVC and PAPVC. So you need to know kind of all the associations with truncus. Now we discussed this. Why does truncus cause early pulmonary vascular damage compared to a VSD? And the answer was that systolic and diastolic pressures are transmitted to the PA, whereas in a VSD, only systolic high pressures are transmitted. Secondly, truncal regurgitation, you have associated pulmonary venous hypertension. Now let me ask you, if you have a truncus and he's untreated, so over time, and he doesn't have pulmonary artery stenosis, he's your common variety of truncus with bounding pulse, with no continuous murmur, with high pulmonary blood flow, and he's little cyanotic, heart failure, somehow he gets missed. His lungs start getting damaged, he has pulmonary vascular disease. When he comes to see you, what two features would suggest to you inoperability in a truncus? So what would suggest inoperability? Yeah, so that is operability. What would be inoperability? So cyanosis would suggest inoperability, and maybe not less than 95, but more. I mean, generally, even when you have mixing lesions, you can be 92, 93. But definitely, if you have a SAT less than 85% in a truncus, less than 90, I would be worried. But okay, if you want to take 85, 86, if you have desaturation, significant desaturation, you would be worried. And absence of bounding pulses, you would be worried. Because if your pulses are not bounding, that tells you what? That now his pulmonary resistance is so high that flow is not going into his lungs. So, patient would have no heart failure, his pulses would not be bounding, and he would be cyanosed. And on echo, absence of bounding pulses is what? No flow reversal in the aortic arch. Right? So that is, it correlates, because now if blood is not going into PAs, does everyone understand why the pulses won't be bounding anymore? Right? Because as the pulmonary resistance goes up, blood doesn't go from aorta into the pulmonary arteries. So therefore you don't have the runoff. So the pulses are not bounding. And as a result, you don't have the flow reversal in the aorta on echo. So the two features would be significant cyanosis and absence of reversal of flow in the descending aorta, which would be very worrisome for inoperability. And you need to remember, in truncal regurgitation, you can have an inoperable patient and he can still have reversal of flow, right? You get reversal of flow in aortic regurgitation. So, when you say this, you have to say absence of reversal of flow in the descending aorta in the absence of truncal regurgitation. Does that make sense? If you have truncal regurgitation, you can have a bounding pulse and you can have reversal of flow and he can still be inoperable. Therefore, the real feature that suggests inoperability in a truncus is cyanosis. If he's significantly cyanosed, you should be really worried about inoperability. Comes to you, you tell me SAT of 70%, send him home. 75%, send him home. 80%, send him home. 85% we'll start saying high thinking, high risk, should we do, should we not do. 90%, okay, borderline. Right, but significant cyanosis, definitely inoperable, or absence of reversal of flow when there is no truncal regurg is a sign of inoperability. If there's truncal regurg, which you see in 20-25% of patients, that, of course, they become harder to assess. All clear on this point? We'll move to the next one. So how do you treat truncus? What's the treatment? Treatment of truncus. Early surgery. How early? When you say early surgery means what? Like 1 day, 1 month, 1 year, 10 years? What is early? So less than 6 months? Any 6 weeks to 6 months? Okay, when do you wait for large VSD? Till what age? When do you close a large VSD? Maximum, when would you wait for a large VSD? Not 1 year. Not 1 year. 1 year is too late. Guys, all of you must read National Committee guidelines. Large VSD must be closed by 6 months. 6 months. If I was standing in rounds at NH, I'd have everyone hold their ears and jump up and down saying 6 months. Large VSDs, outer limit you can wait is 6 months. The reason is some of them will develop pulmonary vascular disease in the first year of life. So in the past with large VSDs, we used to wait 9 months, 1 year, but no longer. Maximum 6 months, you close it off. If he's in heart failure, 3-4 months, right? Now, what did I tell you about truncus? When can they get vascular damage? Earlier than VSD or later than VSD? Earlier, right? So 6 months you cannot wait in truncus arteriosus. Get this very clear. What is the other difference between truncus and VSD? What can happen with a VSD over time? Say a baby is born with a large VSD. What can happen by 4 months? What is the natural history? What are you waiting for? It may decrease in size, right? So with a VSD, you are waiting to see, acha, will it decrease in size? Can a truncus reverse itself? Can a truncus be a non-truncus? Can it disappear? No, right? So why are we waiting? So remember this, that truncus arteriosus can have earlier pulmonary vascular damage than VSD. Remember this, truncus arteriosus will not disappear, even if you and the parents want it to disappear. And therefore, truncus arteriosus must be operated in the neonatal period. So now, answer that question again. What is the timing of intervention of truncus? Give me 1 day, 1 month, 1 year. Answer is 1 month. 3 to 4 weeks. You don't have to do it at 1 day. You wait till the pulmonary resistance drops, baby gets over neonatal, hypothermia, hypoglycemia, all this, some little bonding with mother. But by 1 month, maximum 6 weeks you want to wait, it needs to get operated. There's no benefit in truncus waiting. And the longer you wait, the riskier the operation, because the more pulmonary vascular disease issues you'll have and more pulmonary hypertensive crises post-operatively. So 1 month, truncus arteriosus. Okay, so all clear on this. VSD, outer limit, when will you wait with a large VSD? Outer limit. Outer limit, 6 months. And everybody read National Committee guidelines today. If you don't have it, email me, I'll send it to all of you. Okay, so large VSD, 6 months. AV canal, when will you operate? Complete AV canal. So what is the difference between complete AV canal and large VSD? So complete AV canal, will it disappear? Will it become smaller, the VSD? Never, right? So that is the difference. A complete AV canal has both an atrial shunt as well as ventricular shunt. 2, it can never close. So you don't need to wait till 6 months with a complete AV canal. 3-4 months is average age at which you can close. Some people wait, they want the kid bigger, but ideally it should be closed earlier. So timing of intervention will take into account also natural history. So in truncus, it will never go away. So operate by 1 month, then you will have your best long-term results. So what is the operation for truncus? What are you going to do? What is the operation, intervention? You're going to close the VSD and you're going to put an RV to PA homograft or an RV to PA conduit, right? So And that ideally that homograft that you put should have a pulmonary valve, so you have a competent pulmonary valve. Okay. So what is the long-term issue of VSD closure and RV to PA homograft? What are the main long-term issue? Reintervention because of what? Because of the homograft does not grow with the baby, and so as the baby grows, there's homograft stenosis and conduit it's calcification. But more importantly, it's not, even if the homograft doesn't stenose, you cannot get an adult-sized homograft into a baby, right? You get, what's an adult-sized homograft? What's the size in an adult? What's your typical homograft size in an adult? Like how many millimeters? Okay, 18 to 20, right? Now you have that size homograft in a baby, what will happen? There's no space. So it gets compressed by the sternum. So what's the size you'll put in a baby? Typical homograft size in a baby. 14. Most people will get small baby 10 mm, 8 to 10, 10, 12 millimeters. So if you see as that baby grows, you will need to rechange it at some point and put a bigger size homograft in. If baby is lucky, maybe you get to 8, 9, you get an adult size in. If baby is not lucky, sometimes we change it at 5 years. So it depends on, what happens with the homograft. So that is the issue with really the closure, with the treatment of truncus arteriosus. But having said that, homograft redo is a less complicated procedure than at the first time, because VSD is already closed. Sometimes we just go and do what's called the peel operation, where you will cut that homograft and then patch it open with a pericardium, so you're not changing the homograft each time. So that's the peel operation on follow-up for reintervention for truncus. So is there any other operation that can be done which does not involve a homograft? Any surgical option that doesn't involve a conduit or a homograft? Anyone? Using left atrial appendage? Well, they used to use left atrial appendage to patch it open. They've tried now to do without that. But what is that procedure's name? So in this, what you do is you take the pulmonary artery and attach it directly onto the right ventricular outflow tract by opening up the RVOT. This can only be done in which type of truncus? In which type? Type 1 or type A1, right? Because you need that MPA. So you take the MPA and you attach it onto the RVOT. So this can be done in which age group, and what is the name? Yeah, what's the name of this operation? Who was the first surgeon? It's really named after the first surgeon, Barbaro Marcel, who did the maximum series of this. What age can you do this surgery in? Neonates, infants, older kids? So ideally neonates. So now why is it that you can't? So now, I told you truncus you should operate by 1 month, right? But let's say a truncus reaches you at 6 months. What are you going to do? You're going to assess if he's operable or not. If he's operable, you're going to operate, right? You're not going to reject him because he's come late. Ideal age of operation is 1 month. So in a baby who gets diagnosed in fetal life or at birth, your ideal age is 1 month. But let us say a truncus reaches you late, 6 months or 1 year. If he's operable, he's still pink, he still has reversal of flow, you are going to operate, right? So when you have a kid who reaches you at 6 months or 1 year, I will tell you Barbaro Marcel is not a good option. Your best option, best age at which to do this Barbaro Marcel, which is a Rev-like procedure, is in the neonatal period. And why is that? Because what is the long-term issue with Barbaro Marcel? Why is it that Barbaro Marcel is ideally done? Now MPA stump, see, you can only do this, as I said, in a type A1. So branch PA stenosis, that's for any of the surgery is valve regurgitation. Okay. What will the valve regurgitation be if you did a Barber-Marcel in a 1-year-old? What is the difference between a 1-month-old and a 1-year-old with Truncus? What is going to be the difference? What's the difference between a 1-month-old and a 1-year-old? Why am I telling you to operate on Truncus at 1 month? Because they have not developed pulmonary, vascular, obstructive disease, right? So a neonate has not developed PVOD. Now, when you do a Barber-Marcel, do you have a valve? Is there a pulmonary valve? There's no pulmonary valve, right? You have taken the MPA, you've connected it to the RV. There's no pulmonary valve. When you do a homograft, you may use a valved homograft which has a pulmonary valve, right? So if you do a Barber-Marcel and you take the MPA and you connect it straight to the RV and there's no pulmonary valve, what will you have? You will have pulmonary regurgitation, right? You'll have free PR. Now, what is the difference between pulmonary regurgitation in a tetralogy of Fellow and pulmonary regurgitation in a Truncus arteriosus with PVOD? What is the difference? Okay, no, well, both of them. See, and even in Truncus, you have a high pressure RV, you have a thick right ventricle, you have a non-compliant RV, you have similar things in TET and Truncus. The difference is the pressure, right? So in a tetralogy, when you have cut your RVOT and do a transannular patch, your PA pressures were, what were they? 15, 20. It is a low pressure system, right? Tetralogy of Fellow has low PA pressure, very low. That is a problem. It is oligemic lung fields. So the pulmonary regurgitation is a low pressure pulmonary regurgitation. And that is why the pulmonary regurgitation post tetralogy of Fellow repair is tolerated for many, 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 many years. Yes, 5 or 7% of them may develop RV dilation and may go on to need a pulmonary valve. But all tetralogy of Fellows don't need a pulmonary valve, right, in the future. Some of them need. So why is it tolerated? Because it's low pressure. Now, in Truncus arteriosus, what is the difference? In Truncus arteriosus, the pulmonary artery pressure is high to begin with, right? So if you do a operation like a Barber-Marcel early in life, like 2 weeks of age, pulmonary pressure should drop right away, right? You have not had any PVOD. Pulmonary resistance will immediately come down to normal. And so, hopefully, your pulmonary regurgitation will be low pressure and will be tolerated for many, many years. But if you do this operation when the baby is older, 6 months or 1 year, and he has some pulmonary vascular obstructive disease, and he has some elevated PVR postoperatively, this will be high pressure pulmonary regurgitation. And these patients long term are known to then develop RV dilation and RV failure. And they may need to go on to get early pulmonary valve replacements. So if you look at it, when you do in a neonate, you have the option of doing either a valve homograft and conduit, right, or a Barber-Marcel, and that has a fairly good result. But when you go beyond the neonatal period, when you go into older kids, and then you do a non-conduit repair, a non-valved repair, a valveless tube, or a Barber-Marcel, their results, immediate results may be okay, but you'll end up having issues of pulmonary regurgitation and RV dysfunction. So in neonates, the operation you can do, the Barber-Marcel, is actually preferred because you don't have the conduit, right? So you don't have the issues of having conduit obstruction and conduit replacement over time. Maybe this is the only operation he needs. Because if you do this operation in a neonate, it's like a tetralogy of Fellow, right? He has low pressure PR, which maybe he can go on forever and ever. It may not be that he has to have a pulmonary valve. Also in neonates, the baby is small. Remember, there's not much space. So putting a conduit in there, there's not much space. It's a trickier operation. So Barbro Marcel is a very good option. But in order to do a Barbro Marcel, you need to do it early. You need to do it as a neonate. So in conclusion, timing of intervention of truncus arteriosus, the answer is neonatal period, first 1 month of life, because that gives you the best chance to choose if it's a type 1 or a type A1 with an MPA, you can do a Barbro Marcel. If it's a type 2 or a type 3, you don't have a choice and you've got to do, a homograft repair. Long-term issues with homografts are restenosis and, of course, outgrowing of the homograft needing redo. Long-term issues of Barbro Marcel are pulmonary regurg and RV dysfunction, especially if the PR is high pressure. And therefore, they need follow-up similar to what a tetralogy of fellow follow-up is, but actually even closer if they have evidence of high pressure, high PA pressures post-truncus repair. Okay, I hope that's clear to everyone. So I shall end with this and until the next time.